Now, moving on to our second section, that is the treatment of the radial head fractures. We're discussing all the options, especially the non-operative. Non-operative is actually more of a conservative option using a closed reduction and immobilization. The other option is an operative option, that is the operative reduction and tunnel fixation, and we'll be briefly discussing the radial head arthroplasty as well. Now, coming to the non-operative options, as I told you, the Mason classification guides us to the non-operative option. It is classified as short period of immobilization followed by early range of motion. What are the indication? If it's type 1 Mason, that is an isolated minimally displaced fracture with no mechanical blocks, that is the Mason type 1 injury, where minimum displacement or no displacement, or the displacement less than 2 mm. Usually outcomes are elbow stiffness, with the only problem is actually elbow stiffness, because sometimes you have to keep it for 4 to 6 weeks and eventually results in some degree of elbow stiffness. But overall it has very good results, especially it's almost 85 to 95% of the time it gets very good results. Now coming to the next option, what if we have a Mason type 2, 3 or 4 type of a fracture, then what to do? Then usually the option is operative reduction, that is open reduction and tunnel fixation. Usually worse outcome with 3 or more fragments as compared to less than 3 segments. The point is, the more the comminuted the fracture is, the worse the outcome is. It could be isolated injury, that it could be a Mason type 3 injury in which there is a high degree of comminuted radial head fracture but there is no elbow dislocation, or it could be a complex injury, that is a Mason type 4 injury associated with elbow dislocation as well. Now, indication of ORIF and radial head fractures include Mason type 2 fracture with possibility of mechanical block, that is more than 2 mm displacement of the fracture fragment. Mason type 3 fracture with this comminuted associated with mechanical block, and other complex injuries, especially the Mason type 4 or elbow dislocations. Now coming to the fracture fragment excision. Now the problem is, if it's a highly comminuted fracture, then what to do? Should we just take it out of the radial head, or we just take out few fragments? So that is very important, because taking it out those fracture fragments actually doesn't really help. It results in elbow instability. So the indication usually include the fragments are less than 25% of the surface area, then only you can take them out. Or the radial head usually sits between 25 to 30% of the capitulum surface. Taking out all the capitulum or more than 33% of the capitulum and more than 1/4 of the radial head would result in a gross instability of the elbow, especially to the valgus stress. So that is something you need to remember, because otherwise it will be resulting in elbow instability and the patient will keep on complaining of pain and recurrent elbow dislocations. Outcome, even a small fragment excision may lead to instability. This is something you need to remember, and that is when we are talking about radial head arthroplasty, that the concept of radial head actually fragment excision comes in. You cannot just excise unless there's specific indication of radial head excision. Even if you excise it, you have to replace it with the radial head arthroplasty. Now coming to the radial resection, completely taking out the radial head, usually it's only indicated in low demand sedentary patients. If a patient comes to you, let's suppose it's a 85-year-old male or a female with a history of fall resulting comminuted radial fracture, probably yes, you can take that out if it's continuously painful. But in young patients who are active, you cannot take them out. Even if you have such a kind of a comminuted fracture in which there is a lot of comminution, you have no other option but to take it out, then you have to replace it with radial head arthroplasty, especially in a delayed setting of continued pain of an isolated radial head fracture. Contraindications: presence of destabilizing injury. If there is associated ligamentous injury, then radial head excision would be disaster for the patient. If forearm intraosseous ligamentous injury is also there, then that means basically it's creating both bone. There is no actually relation of both forearm bones, and the excision radial head will produce gross instability. Coronoid fracture, especially more than 33%, that can also produce instability as well, or MCL deficiency. Why? Because the most important this valgus strain to this ulnar movement is actually the radial head. If there is MCL deficiency as well and you have removed the radial head, ulna will go towards laterally and it result in a lot of dislocations. Now coming to the radial head arthroplasty. In young adult patients, either you cannot go for complete excision of the radial head. Even if you do, then you have to replace it with a radial head arthroplasty. So important is the indication is a comminuted fracture, especially Mason type 3, in which involving more than 25% of the surface area of the radial head with 3 or more fragments, or if for example Mason type 4, in which there is elbow dislocation as well, and ORIF is not feasible and involves greater than 25% of the radial head. In that cases, sometimes there's no option but to take out all the multi fragments of the radial head, and eventually after radial head excision you can just replace the radial head with a radial head arthroplasty. And then other is elbow fracture, dislocation, or axial prosthetic fractures. So these are all Mason type 3 or 4, in which a young adult patient you probably are going for radial head arthroplasty. Why radial head excision is controversial? That is because exacerbates elbow wrist instability, proximal radial migration, and ulnocarpal impingement. All these things then can result in pain, arthritis with the elbow joint. Later on there will be stiffness and problem for the patient actually. So radial head needs to be replaced. Coming to the retrograde titanium nail reduction stabilization, this is a newer technique being utilized especially in the case of pediatric population. What usually is done is that, as you know, the radius is a bone which has a very large area around the wrist joint. The surgeon goes in through the metaphyseal area of the distal radial ulna, and that is the point it goes intermedullary, engages the fracture fragment within the proximal radius, reduces it by close reduction means, and then replaces it with a titanium nail. This is actually not yet considered mainstream treatment, but it has been done some institution, and some have advocated its use as well. Why? Because even if it's a Mason type 2 injury in which there is more than 2 mm displacement, you can engage the displaced fragment, reduce it back without opening up the area, and that's kind of resulting in a close reduction kind of a technique. Plus the nail is intermediary, so therefore you do not need to do a lot of tissue dissection as well. So it has its own pros and cons, but yes, it's being done at some areas, some centers around the world, and it is especially in the case of pediatric population. Outcomes, or overall it has shown promised outcomes and good outcomes most of the time. In this section, we've briefly gone through the treatment of the radial head fractures. That is why the classification given with the Mason comes handy, because treatment depends upon what is the type of the injury. Type 1 is either undisplaced or minimally displaced and can be managed by close reduction and immobilization in form of conservative management. If it's type 2 or 3, that is usually either you go for open reduction, internal fixation, depending upon it's how much the fracture fragment is there. If it's type 3 and 4, in which there is more than 25% of combination, or the associated elbow dislocation, then we have to see what is the functional status of the patient. In a young adult patient, we either have to go for ORIF or radial head arthroplasty, along with the repair of lateral collateral ligament and medial collateral ligament. Or if it's an old patient with sedentary lifestyle, we can go for radial head excision, or the most of the fracture fragment excision, especially in the older patients only. Thank you very much. Keep watching sqadia.com.